So everyone, welcome to PICU, MICU, COVID, oh my. So this is our first webinar about adult intensive care for pediatric providers. With everything that's been going on with response to COVID, a number of med peds, pediatricians, and hospitalists got together about 2 weeks ago and founded something called the Popcorn Overflow Contingency Response Network, short for POPCoRN, at POPCoRNetwork.org, which is in the chat. And we've been just trying to provide educational resources so that everyone feels most comfortable practicing outside of what they were originally trained in. Take it away.
Yeah, so basically, if you want to check out on the website, you can visit POPCoRNetwork.org, and you'll see lots of wonderful resources for this. I'll also make a selfish plug for a paper coming out in Pediatric Critical Care Medicine this week that a bunch of med peds intensivists got together and wrote on basically how to turn your PICU into a MICU. So keep an eye out for that. It has been accepted. We've got to look at the page proofs, but that should also be a written guide for a lot of what we're going to talk about today. So my name is Phil Verhoef. I am trained in med peds, and then I did a MICU and PICU fellowship at the University of Chicago, and have since relocated to Hawaii, where I also practice in both the MICU and the PICU here. And so we have an awesome panel of a good mix of folks who do both adult and pediatrics. So hopefully we'll have a great discussion. So I'll let you guys go ahead and introduce yourselves. Arun, do you want to get started?
Yeah, I'm Arun Kanapan. I'm one of the pulmonary critical care docs at the University of Colorado in Denver. And I am med-peds trained by background. I went to Penn State, where David currently is. And yeah, my interests are in medical education, and hopefully we'll put on a good show for you guys.
All right, Deanna.
Hi, I'm Deanna Behrens. I'm a pediatric critical care doctor in Chicago, Illinois at Advocate Children's. I trained at Miami in med peds and then ended up doing a PICU fellowship at Washington University in St. Louis. So even though I haven't done adults for a while, when all of this came up, I kind of became the go-to person at my institution for preparing PICU to take care of MICU patients. And then just recently, in the last week, they sent out a call asking for any pediatric ICU providers to take care of adults in the actual medical ICU at one of our affiliate hospitals. So I started there. And I have to say, it feels kind of just like home. It felt very similar to what we were doing. Felt like we were going right back into it. And I want to give a shout out to Dr. Kara Von Zicklin and Dr. Travis Maddox, who are also doing that, as well as Dr. Vinod Havalad. So it's been great, and they are so wonderful. I've been very impressed with everybody at that hospital. Oh, cool. And my other interests are, pediatric ICU rehab with Sapna, who I believe might be on here. And then I do a lot of advocacy work in my spare time.
All right, Mihir.
Hey guys, my name is Mihir. I'm a final year pediatric critical care fellow at Cincinnati Children's. I did my residency here. As compared to these guys, I have no adult training background, so it's a purely pediatric perspective.
Awesome. And last but not least, Nick.
Hi, so my name is Nick Mark. I'm a internist, PulmCrit trained adult doc. I have 2 kids, but I have no experience in pediatrics whatsoever. So these guys are going to teach me a lot over the next hour.
Great. And so none of us, just to get this out here, have any financial disclosures. And I want to just read this disclaimer as well. This presentation is for educational and informational purposes only. The topics discussed should not be used to diagnose, treat, cure, or prevent any diseases or conditions. The views and statements expressed in our video are solely those of the hosts and should not be interpreted to reflect official policy or the opinions of any specific institution or entity. The information is subject to error and changes, and as such, the hosts cannot be held liable for such events. And you should take care to verify everything we say. So let's dive into the webinar. The way that we're going to basically structure this is that I'm going to serve to moderate because I actually still work in both of the ICUs that are sort of relevant in this, but we'll lean on hearing both from the PICU docs here as well as from the adult MICU docs, sort of what their different experiences are related to various different topics. We're going to set this up roughly by organ systems, and also sort of reflecting the questions that the Network has really been hearing that people have about, how to take care of adults in a PICU. We do have the capacity to answer your questions live, so if you want to use the chat function, you're more than welcome to throw questions up there, and hopefully David or Marie or one of the others who are sort of Popcorn Network folks will channel those to us as well, and we'll try and address those in the course of things. And so our first subject is neurology, and more specifically, we want to get into it a little bit in what's different about taking care of adults compared to taking care of kids as far as pain and sedation in the ICU. So I think I'll first turn it to Deanna, and ask some leading questions. What do you use in sedation? What's been your experience, and what questions would you have if you were taking care of an adult patient rather than a pediatric patient?
I am taking care of adults now, so this is very relevant for me. Thank you for letting me start. I would say, first of all, my go-to sedation medications typically are going to be fentanyl and Precedex. When I started this maybe 10 years ago, we used a lot more Versed, but now we almost never use Versed unless we use, so we're trying, although I think that there are still some pediatric ICU practices that are using that. So for a lot of reasons that are probably a little bit beyond what we can talk about right now, we're really staying away from Versed as an infusion. Sometimes we'll give PRN, Ativan, or something if they have a need when they're intubated and mechanically ventilated, but we're trying to stay with fentanyl and Precedex for the most part. There are a couple of other medications that, of course, will bleed in if they need it. The other thing that I would say for us is that we recently started the PICU Up with Dr. Kachadkar. And so we are doing a lot of stuff in the last probably year or two that we hadn't been doing before. So Dr. Maddox does a lot with our sedation side of that. So we use SBS to titrate. So SBS is the state behavioral scale. And we score the kids kind of on a scale of completely paralyzed or comatose all the way to very agitated and pulling out the tube. And we like it kind of in the middle there. So this is more, I think, about how it's different from the adult side. So I will turn it over to a couple of other people too. But I will say that just in the short time that I've been on the adults, I have seen that they've used more propofol, which we rarely use. Is that correct?
Totally. Arun?
Okay, guys, I'm going to grab the screen and go through a couple of key concepts in adult sedation. So we have a guidelines issued by the Society of Critical Care Medicine called the PADIS Guidelines, most recently updated in 2018. That's easily Googleable. That goes through by priority the things that we think about in adult sedation based on a lot of randomized critical care trials over the last 2 decades. And so PADIS stands for pain, agitation, delirium, immobility, and sleep. But I'm going to focus on the first 3. The reason that pain is first up on this is because we found that if we give propofol or benzodiazepines in order to make adults more synchronous on the ventilator, we actually have escalating use of those medications because we are not treating underlying pain. So the emphasis on these guidelines is to start with pain control first. And we use different scales. We have CPOT, we have RAS, we have nonverbal ways of assessing pain that's usually nursing driven. So if you're going to implement this in the pediatric ICU, like with everything else we're going to talk about, I highly implore you guys to contact your nearest medical ICU and see what protocols they have for nursing, respiratory therapy, and so forth in order to help streamline it in your own facility. Real quick, going through pain, the main things that we use here are opiates, and as mentioned, fentanyl is probably the main one used, but because of COVID, the United States is actually in a national fentanyl shortage. So we've started using more morphine as well as hydromorphone, which I'll just call HM. And the things to keep in mind with these, fentanyl is fairly short acting and washes out quickly. It's hepatically clear, just like the other 2. Morphine and hydromorphone to some extent have some active metabolites that can be accumulated in renal dysfunction, so people can be excessively sedated with that. in addition to this, you can also use multimodal pain approach such as acetaminophen, gabapentin, tricyclic, or SNRI for pain control in addition to this. And the PADIS guidelines emphasizes the use of bolus or intermittent dosing before you start drips or infusions. And the reason is to minimize sedation and pain control as much as possible, to keep the patient as awake as possible, to maintain synchrony and be safe, but also to be able to interact, to be mobilized, that sort of thing. Under agitation, which is your general sedation, what we think of after this, the main drugs that are used are propofol. I'm going to just put dexmedetomidine, which was Precedex previously mentioned in case you're an international person, dexmedetomidine, and then benzodiazepines I'll call BZD. So benzodiazepines, we're talking about midazolam and lorazepam mostly, and each of these has pluses and minuses. So propofol is great. It's fast on, fast off, even though the half-life is, I think, over 24 hours. The effect on the CNS is within a few minutes to hours. And so it's really great for sedation in most cases, and you can use this in liver dysfunction as well. The main things to worry about in pediatrics, you probably have heard about this really bad propofol-related infusion syndrome, which is a catastrophic cardiomyopathy, rhabdomyolysis lactic acidosis, that occurs in high doses of propofol. We found in adults that if you cap off at a certain dose, which is about 80 micrograms per kilogram per minute, we do not see this a whole lot, but we do check triglycerides and CK going into these infusions to see if there's any signs of propofol-related side effects. Propofol can lower your blood pressure and does cause bradycardia, so this is something to keep in mind. Dexmedetomidine is really great for light sedation. It is an anxiolytic. It does not cause amnesia, so patients will be awake. They can breathe on their own. They can be chill, but it's not useful for true sedation. It's just an adjunct. The problem with dexmedetomidine is that the half-life is hours, and sometimes you run into the bradycardia and low heart rate that comes from a centrally acting alpha-2 agonist, which is its mechanism. Propofol is a GABAergic agonist. So if this starts to happen, it may linger for hours. So that's the downside that we usually see with Dex. And then benzodiazepines, midazolam, lorazepam, they build up in hepatic dysfunction, so they can lead to prolonged sedation. And there have been a lot of studies that have shown that these are potentiators of delirium, which is the next thing we'll talk about. So they are used as boluses more likely and drips much less often. So just something to keep in mind. Oftentimes you'll see somebody on fentanyl infusion with PRN or as needed lorazepam, midazolam. Now, delirium is something that is very difficult for us in the medical ICU. There have been many trials, and most recently the MIND USA trial, which is in the New England Journal, that basically showed that there are no good pharmacological options. It was haloperidol, an atypical antipsychotic, and placebo looking at delirium days, and there was no difference in each of the groups. One of the thoughts was that most of the patients in this trial were hypoactive delirium, so there is some thought that maybe haloperidol might be useful in hyperactive, but most centers, I would say in the United States, no longer use a scheduled antipsychotic when someone is delirious. And the big tool that we use is called a CAM ICU scale, which is something that can be performed by nursing to see if a ventilated nonverbal patient is delirious or not. So the general gist of what we do is the ABCDEF bundle, which is also part of the SCCM. And you can Google this as well. A is for assessing and treating pain. B is for waking up patients and letting them breathe. C is for not keeping everyone on drips all the time. D is for assessing delirium, making sure day-night cycles are improved. E is early mobility, and F is family engagement. And these are the only things that have really been shown to reduce the incidence of delirium. So I'm going to stop there. I've been talking for a while and just toss it back to you, Deanna. What do you, does anything pop out at you as something really different than in PEDS? Are there any further questions from you or Mihir?
Well, absolutely. So I want to give Mihir a chance to talk, sorry. And then if I can jump on after he's had a chance.
Yeah, I think delirium is extremely challenging, and we've certainly, over the years, reduced our use of Versed and ketamine um, for patients who are intubated. And I think typically we do non-pharmacological methods to address delirium, as you mentioned, Arun. And then Seroquel probably is the most commonly used agent, followed by haloperidol. But I think you're absolutely right in saying that hypoactive delirium is a common problem that's not addressed, or that's challenging to address. I think for most parts, um, our choice of pain or sedation agents are about the same, with a thought about hemodynamic stability in kids who are on higher mean airway pressures when they're intubated.
Yeah, I think all of that is great. And I actually want to say that this is one of the things that I think we can or are in the process of learning from adults. In the past, we kind of kept the kids very well sedated because everybody was very concerned about safety and extubation and all of that. But we're starting to catch up to our adult colleagues. And again, there's been a lot of work out of Hopkins on this. So instead of the ABCDEF bundle, which has been widely used in the adult side for quite a while, we're starting to use this PICU up bundle that has been validated, that has been shown to be safe at Hopkins and now is going through some other trials, but it's some of the same concepts. So for us, prevention of delirium, and I'm sure for you guys too, prevention of delirium is better than treatment. So we try to keep kids on schedules. We try to, turn off the lights at the normal bedtime, wake them up when they would normally wake up. We try to get PT and OT involved early. And just to clarify, which I'm sure everybody knows, early mobilization doesn't always mean that everybody on a vent is going to be walking, but it could be maybe they can be sitting up a little bit more, interactive a little bit more. Getting them communicative devices can be helpful too, because one thing that makes people delirious is not being able to communicate, not sleeping, getting more medications because people think that they're delirious. And so it's a vicious circle. So sometimes if you can get somebody to communicate, lighten the sedation, and kind of go from there, it might help. And then for kids too, just to put in a plug, babies can cry even when they're intubated. Babies can cry even when they're on a drip, and they don't always need a sedation bolus for that, because as an adult, the more medication you get, the higher risk you're going to have for delirium. So that was a great summary. Thank you for putting that up there in a really clear, cohesive way. And I'm glad that this is one of the things that, although there are differences, that we're kind of moving in the same direction on. One other question I had for you guys that I wanted to throw out there is how you guys manage withdrawal. I think in pediatric ICU, at least in my pediatric ICU, we're more likely to put patients on methadone or clonidine, or if they've been on Versed, which we try not to do, on Ativan weans. But I haven't found that as much on adults, maybe because you guys are using more propofol or less of those medications that need that.
Let me just piggyback on that as well.
Sorry, lorazepam. I said Ativan. I apologize.
Yeah. Just piggybacking on that question, I wonder if either of the adult intensivists want to comment on the use of enteral, say enteral morphine, enteral methadone, enteral diazepam or lorazepam as a way of reducing potentially the amount of IVs that you use.
So let me, if I may, jump in. I want to just add one thing, if we can, on here to sort of think about, which is think about pain control, which is non-opioid, and specifically, scheduled acetaminophen or paracetamol, using NSAIDs, and also thinking about local means of pain control. So I'm a big fan of using a lidocaine patch, using a nerve block, and using low-tech stuff like elevating a swollen limb, using hot packs, cold packs, that sort of thing. So I take a perverse delight in controlling pain with low-tech, non-opioid stuff. It's always gratifying when you can do so. To that second point, I think it's incredibly germane to the current COVID epidemic, because drug supplies are running low. There's a shortage of fentanyl. There's likely to be shortages of others. And I think one of the things that we can do is we can be more sparing about drugs, but we can also use opioids that are oral, given enterally in the ICU more. And one great way to do that is, you can use scheduled oxycodone the same way you might use a drip. You can use hydrocodone the same way. And actually you can use, there's a few other meds that, we're using more and more. Like, for example, you can use phenobarbital, which we typically use in an alcohol withdrawal context, but you can use that for agitation as well. It's quite effective. And then finally, kind of a favorite drug of most people from an ED background is ketamine. And ketamine is kind of a funny one because it has analgesic and sedative properties depending on the dose. So it can sort of variably fall into both of those two categories. That's a good option to consider in your back pocket. And one of the best things about it is it has very favorable hemodynamics, i.e. it doesn't mess up your hemodynamics.
Great. Let me keep things moving. I just want to make one other comment, and that is that typically dosing in kids is weight-based.
Yes.
Typically dosing in adults is not. And so for several of these drugs, you may run into the sort of limit depending on, and that's typically set by either your local pharmacy or your local nursing staff. At most of the places I've worked, we typically won't go above a fentanyl infusion of around 300 mics per hour. Morphine would typically be, around 10 to 15 milligrams per hour. Propofol we tend to like around 75 as our max, 75 to 80. Midazolam 10 to 15 milligrams per hour, and dexmedetomidine will run up to 100 mics per hour or 1.5 mics per kilo per hour. I've run it quite a bit higher than that in kids, particularly for procedural sedation. But I believe the testing in adults maxed out at around 100 mics an hour. So make sure that if you're beginning to adapt yourself to take care of adults in a pediatric context, make sure you're not necessarily going to adapt your weight-based dosing. And that said, as a general rule, if you want to know how to convert weight-based dosing to adult dosing, you can either use 40 kilograms or 60 kilograms. Typically, anywhere between 40 and 60 is where you transition from pediatric dosing to adult dosing. I think we could probably spend a whole hour on talking about pairing awakening trials with breathing trials, where the idea there is you wake them up and at the same time you do a spontaneous breathing trial. I'll defer that for the moment, but let's go ahead and move into pulmonary. And so for pulmonary, I wanted to give Mihir the chance to ask some pediatric-based questions and then see where we go from there. And some of the questions specifically are maybe around how do you manage hypoxemia non-invasively, and then how do you think about getting patients onto the ventilator, and then how do we think about getting patients off of the ventilator? So Mihir, I'll throw it in your court first. Unmute yourself, Mihir.
Sorry, thank you, Phil. I think for most pediatric patients coming in with severe hypoxemia, we would at least try high flow or non-invasive positive pressure first. Typically about 2 per kilo flow on high flow. There are concerns raised given the concerns for COVID and aerosolizing procedures, whether these can be used. I think I would try it, taking necessary precautions, but in terms of intubation, our standard approach would be to perhaps start someone on pressure regulated volume control and then transition to pressure control ventilation depending on what their peak pressures look like, with a PEEP of probably, start with 6 to 8 and then go up as needed. And then, I think once you optimize their ventilator settings, optimizing things like sedation, like we've alluded to, other adjunct strategies would be, use of neuromuscular blockade and prone positioning, much like in adults. I think for me, the key difference has been delving into the adult literature and use of high frequency oscillation ventilation. I think that's where we differ significantly. The Oscillate and Oscar trial came out now almost a decade ago, which showed either no benefit in the Oscar trial or worse outcomes with the in the Oscillate trial. But outside of those, I think most of the things that we do in kids translates fairly readily into adults. I know proning a child and proning an adult can mean drastically different things. For most parts, as smaller kiddos, it's relatively easy to flip over. And I'd like to hear from you guys as to your approaches, because I know that's fairly standard in the adult work.
Nick.
So yeah, lots of great stuff there. I think you all have been ahead of us by at least 5 to 10 years on the use of non-invasive. You know, we tend to reflexively intubate a lot more adults, whereas I think in the peds world, you know, you guys are much more comfortable doing cool things like BiPAP with a NAVA trigger and stuff like that. I've never seen adult intensivists do that, but I've seen that happen in the PICU before.
Mm-hmm.
You know, I think when we think about non-invasive ventilation in the context of COVID, there's really two things that I think about. One is, what is the risk of an aerosol generating procedure? And two is, what is the risk of waiting too long to intubate? So talking about the first one, what is the risk of aerosol generation? So you can think about this as kind of a spectrum. If you do nasal cannula versus high flow nasal cannula versus non-invasive ventilation with some sort of mask interface, there's an increasing amount of aerosolization as you go up that spectrum. And there's pretty clear data from some interesting studies they've done with literally smoke and lasers to measure the amount of particles escaping, that non-invasive with a mask interface has a lot more aerosolization than high flow, which is more than nasal cannula. And all of this depends on flow rates. So remember that it's not just the interface, it's also how much air. The reason why this is practically important is, I think from a safety and operations perspective, you can reasonably put people on a nasal cannula anywhere, but you should think very seriously about where it is safe to put people on a high flow cannula, and certainly where, if at all, you're going to use non-invasive positive pressure. And what I mean by that is, these, you know, in my practice, these people have to be in a negative pressure room, and you have to make sure that the staff around them are wearing appropriate PPE, which ideally means PAPRs, but N95s that are fit tested are fine.
And what about once, sorry, I was going to say, what about once they're intubated?
So once they're intubated, they should probably stay there, though theoretically, if you have them on a closed circuit and you have HEPA filters, the risk is lower. Though if there's ever circuit breaks, and there's often circuit breaks, you know, there's this pretty significant risk that accompanies that. So it depends. If you have the means to put them in negative pressure, you should do so. What we've done in some of the hospitals where I work is we've converted a lot of rooms to negative pressure rooms, like rolling these big ventilation units into the rooms, which makes the room so noisy you can't hear each other, but it makes you safer. So that's the first point, the risk of aerosol generation. So, you know, there's a trade-off of increased oxygen delivery, but increased hazard to staff. The second thing to think about is the risk of waiting too long. So it's very tempting to, you know, take control of the situation. If you intubate somebody, you have protected them in many ways. You've also exposed them to a lot of hazards, right? There's non-trivial risks of being intubated, both of putting the tube in and then being on a ventilator. So the other thing is that we're learning over time that a lot of patients with hypoxia or hypoxemia from COVID are not hypoxic. Their organs are adequately oxygenated and perfused, and they don't necessarily need a tube. You know, there's some amazing videos on the internet of people on their phone with a sat in the 70s, right? Somebody who's sending cogent, you know, tweets probably doesn't need a tube for hypoxia, you know? So we're trying to be more parsimonious about who we put tubes into. But the hazard is you wait until that person is really, really hypoxemic and really hypoxic, and then they could die when you put the tube in. So my advice to all of you about that is have a conversation with the bedside nurse about what your trigger to intubate is going to be. So for example, you could say, like, you know, Mr. X is here on day 3 of COVID. He's likely to get a little bit worse, but he's doing okay on high flow. However, if his work of breathing increases or he gets somnolent, that's going to be our trigger to intubate. So don't make your decision based solely on a number, really make it a gestalt and use things like how hard are they working and how well are their organs perfused as evidenced by their mental status, urine production, etc.
Great. And one thing I want to add in terms of intubation, on the adult side, we tend to do much more either rapid sequence or so-called awake intubations, where you'll literally just give them a lidocaine neb to numb the vocal cords and just get in there and put the tube in. Or you might give just a quick squirt of propofol just to take the edge off for a second and then intubate. Whereas, you know, when I was taught to intubate in pediatrics, it was give them a whopping dose of fentanyl, a whopping dose of midazolam, and then give them a paralytic and then take the airway. And so I think the point I think to make is that intubation itself is not trivial. It's, you know, in some ways it's harder to intubate a kid because it's just so much smaller. On the other hand, you don't have kids that weigh 300 pounds with necks that are humongous and really difficult to manipulate the airway. And so as has been pushed out there, you know, the people that are intubating, at least in COVID, should probably be your most experienced intubators in general, whatever that service is. Nick, what about once they're on the ventilator? What about once they're on the ventilator? Oh, sorry, Deanna, you got a question. Unmute yourself.
Oh, yeah. No wonder you couldn't hear me since I have myself muted. Thank you for bringing up those points. A couple of other things that I had read, at least, was that you should be using neuromuscular blockers for intubating for COVID. Is that something you guys typically do, perhaps more so than you might normally? And then also, I don't know what your routine use of like GlideScope or other video laryngoscopy procedures are, but we have found in pediatrics, and I'm sure you guys have been doing that as well, that we're trying to use that more. Of course, in the tiny little babies, for me, it's harder to use the the VL sometimes, but is that something you guys have been doing? Or
yes. Somebody else want to take this one and then I can jump in after?
Yeah, I will tell you that pulmonologists are those that would love to do intubations in the medical ICU, but the guidelines specifically around COVID amongst many medical societies say you need the most experienced airway specialist to place these tubes. And usually for us, that's anesthesia. And they come in full PPE garb with PAPRs, and they set every single thing up. They talk to the patient, and they paralyze and immediately get the tube in. First pass with a video GlideScope or whatever the brand of the scope is.
And then we've also read about not using cricoid. Is that?
Yeah, let me jump in here to say, so I mean, so in my hospital, I'm the one intubating. I am unfortunately that person. So I can tell you kind of the 5 things that I sort of think about on these folks. First is, do I truly need to intubate? We talked about that a little bit before. Second is, how can I stay safe personally and keep my team safe? And that really comes down to 2 things. What's the smallest number of people who can be in the room? You know, I want 1 person pushing meds. I want 1 person who's going to be my sort of ventilator and handing me stuff assistant, and me. And 3 people is enough, maybe 4, no more than that. The third is, what problems can I anticipate and remedy in advance? So position these people perfectly. Slide them up on the bed, get the towel roll, get them perfect at an angle so they don't lose their FRC. Pre-oxygenate them like crazy. Nasal cannula cranked up to 15. Non-rebreather over that. Get as much nitrogen out of their lungs as you possibly can. And then think about, like, okay, I have a bag of fluids connected, ready to bolus. I have a stick of phenylephrine out that we can push. And I have my sedation ready for afterwards, because everything takes 10 times longer in COVID, getting it in and out of the room. Finally, okay, what is my approach going to be? And ideally, we talk about this outside the room when we can all hear each other. My approach is pretty much always the same, though, which is pre-oxygenate like crazy. I like ketamine and rocuronium. Ketamine because it preserves airway reflexes and keeps them breathing. Rocuronium because it's pretty quick on, especially at the 1.5 mg per kg dose. And because you don't have to worry about, is their potassium abnormal? Am I going to give them an arrhythmia? I try never to bag them. I try to just pre-oxygenate, push meds, and then go with a glide scope or video laryngoscope. That's the only way I've intubated these folks. And one pearl that I would share is we tend to keep these patients fairly dry. And, you know, COVID intubations happen in one of two ways. They're either the person comes into the emergency department and they're crumping and they get intubated right then and there, or they're in the hospital and they deteriorate over time. And the people who are in the hospital and deteriorate over time are dry. And I've had the scope and I've had the tube and just like everything else get hung up on dry mouths. So lube that stuff up like crazy. Take the extra 30 seconds to do that. It will save you a lot of trouble. Finally, get your connection all set in advance. So you have your ventilator circuit, you have your HEPA filter, and then if you put your inline suction on too, great. You can even put your capnograph on there as well, downstream from the HEPA filter. So you only have to put it on once. You're not breaking the circuit multiple times.
Do you clamp the tube before you even get that on, like after you've intubated, before you get that on?
So I've done that before. Increasingly, I'm thinking you may not need to do that if you have the HEPA filter in the right place. If you break the circuit, but there's a HEPA filter, the problem is they will de-recruit, but if you've just intubated them, you haven't really recruited them anyway.
Sure.
So I think it's fine, instead of like trying to find a big enough Kelly clamp and get it on there just so. So I think probably for somebody who's on the circuit on high PEEP, I would clamp, but for somebody I've just intubated, I would just make sure that virus isn't spewing out the tube.
I just wanted to say a couple of things too. So in our hospital, my main hospital, we have an intubation team that's not specific, or that doesn't come to pediatrics necessarily. So we are the intubators. So we do exactly what you said. We have 3 people in the room for intubation. And at the beginning of every shift, I meet with the charge nurse and we meet with RT and designate those people so that we know who it's going to be. And we treat all of our patients who come in as PUIs until proven otherwise, and sometimes even then. The other thing for us is that, and probably for a lot of your guys' vents as well, sometimes we can take the brain of the vent and put it outside. So we are able to set stuff up off of there too. And then once the tube is in place, we have had, this is something that maybe we can talk about in another time, but some of our RTs are concerned about leaving the filter on after they're intubated versus during the intubation we'll leave it on, and then some of them have wanted to take it off. But what I've noticed on the adult side is you guys typically keep the HEPA filter in place the entire time. Is that correct?
Are you noticing that they're getting waterlogged, or what's the reason?
Yeah, they're worried for kids about increased dead space and some of the other stuff that maybe are a little bit less critical in adults when you're trying to ventilate, you know, somebody who's 3 kilos versus an adult-sized person.
That makes sense. Yeah, we've generally been trying to keep it on, and we've been running these circuits without a heated humidifier.
That was the other question I was going to ask too. That was one of their other concerns.
It's actually kind of amazing to me how much less secretions people have when you blow non-humidified air directly into their lungs. Probably not great for them. We do it for reasons of safety, but it is interesting. You know, you just see much less like copious secretions in folks when you're not putting all the moisture in.
And let me ask. Oh, sorry. Go ahead.
Let me ask. What do we do once they're on the ventilator? Let's just spend a little bit of time talking about that.
Sure. So, you know, I think there's, you know, depending on kind of where you grew up as an intensivist, you tend to gravitate to either volume or pressure. And I think, you know, they're equivalent, right? It's kind of like, do you like to set one dependent variable or the other? I grew up in, you know, volume shops. So that's kind of my default. I love pressure regulated volume control as well. And I reach for pressure control sometimes. I think, you know, to quote one of my mentors in training, the best mode to use is the one that everyone understands. So whichever one your RTs and nurses and you are comfortable with is probably the one to stick with. It makes me very nervous to see people trying to pick up APRV for the first time. It's probably not a great idea to try something totally new on a really sick person.
Yeah, I think that's a great point. There's never been a study that proved superiority of pressure versus volume control methods. Now, where I grew up, we largely stuck with volume control and really specifically AC volume control with constant flow, in part because that was what was used in the ARDSNet trial. And so we set it for 6 cc's per kilo because we know that that's what works. You know, my counter to that is always, boy, that seems uncomfortable to do constant flow at 6 cc's per kilo. PRVC with its sort of decelerating ramp of flow seems like the best of both worlds in that you can set a 6 cc per kilo tidal volume, but it may feel a little bit better than slamming a volume in. But I think go ahead.
What's your practice in terms of targeting plateau pressures and driving pressures?
Let me actually jump in here. So we want to keep going with the different topics. So let me just toss out the two things that we know that works in ARDS. So the two things that we know that decreases mortality is what's called low tidal volume ventilation, which is our somewhere between 4 to 6 milliliters per kilogram tidal volume breaths obtained in whatever way your institution feels comfortable, be it pressure or volume control. And that's based on ideal body weight because some adults are very large. And so this is a component of gender and height. And there's cards out there, reference cards that respiratory therapists can use, and you can even use arm span, let's say if it's an amputee or some other type of congenital deformity. So this is the ARMA trial, and that was in 2001 New England Journal, and it was the biggest landmark trial, has been on every board exam I've ever taken. That's number one. The second one is proning, and we've mentioned it a little bit, but the big trial that this is based on is ProSiva. And ProSiva is also a New England Journal trial from 2014. And what this is severe ARDS, where the PA to FiO2 ratio is less than 150, and it was done early, meaning within 24 hours of intubation. And people were prone for 16 hours and then flipped for 4 to 8 hours if they met the criteria. And what this showed was a improvement in mortality, and the median times people had to be prone was about 3 days. Now, I will also say that our institution is starting to implement what's called a proning team, just like an intubation team. If somebody has COVID with severe ARDS, we have a dedicated team of nurses and respiratory therapists that go into the room and flip the person prone and then back over in a very streamlined fashion that I recommend people look into, especially because the BMI of even a 25-year-old adult can be very large. And if you're not used to doing that kind of motion, it's a very team coordinated effort, and having a well-oiled team is very important. There's a lot of other stuff that comes into ARDS treatment, keeping people dry as opposed to very wet, reducing the use of sedatives, reducing the liberal use of neuromuscular blockade, only using it when you're in a pinch, maybe using high PEEP. All of that stuff is kind of patient dependent for a large part, but these are the two things that I would recommend pediatricians absolutely look at and know as far as adult ARDS.
I just wanted to make a couple of points too. I think all that is really great. One, there's some people in the comments who have some really great suggestions. So I recommend people following along in the comments. And two, another thing, so we have the proning team as well, and it's great. But what do you guys think about proning in non-intubated patients? That's a question from the comments, but also one I was going to ask.
Do it.
So, why does proning work, first of all? What's the deal with proning? So there's a couple theoretic rationales. One is that you have a lot more lung posteriorly than anteriorly. So if you lie on your back and you have dependent edema in the lungs, you're losing a lot more lung to it. That applies whether you're intubated or not. The other rationale is secretion clearance. It's easier to get secretions out of your lungs if gravity's helping as opposed to working against you. That also applies if you're awake as opposed to intubated. So I think the theoretically it should work just fine, and that has been confirmed, I would say, by my experience and by others, that many of these patients who are on high flow cannula or other modes of oxygen delivery can prone themselves. Yep. And this is great for a number of reasons. One, it really does work. You can get their sats up 5% or more in some cases. Two, it's moving them, so it's mobilizing them a bit. And 3, it's also kind of a way to assess, like, are they with it? Like, you give them instructions like every 2 hours to, do this. And if they're following those, it tells you they're pretty on top of things. So it gives you a readout both of their functional status and their mental status, in addition to improving oxygenation for some of them.
That's a really great point. I hadn't thought of that last point. We actually, in my PICU prone kids, a decent amount, because like Phil was saying, it's easy to do when you're real little to flip them over. And it works a decent amount of the time. So I'm proning as well, or as Dr. Steve Cook was saying, tummy time for adults.
Great. Love that.
And I would also say, let me just add real quick about the proning while not intubated. It can give you a false sense of security. If your oxygenation improves while prone, you might lose that safe time to intubate by relying on proning too much. So that is why our hospital system has not made it a mandate that floor patients be prone with COVID, because we thought that if they're bad enough that you're thinking about proning for oxygenation, they probably should be watched in a step down or ICU unit a little bit more closely.
Yeah, no, I think that's a great point. I mean, to be 100% clear, there has never been a study that looked at non-intubated proning. But I'm hearing more and more anecdotes from people who are finding that it works great, potentially as a way of fending off the tube. Let's just switch gears a little bit into cardiovascular. And I think the big points that I want to get into the discussion are are there differences in pressor choices? Are there differences in CPR or ACLS between adults and kids? And then is there anything else that we need to be particularly attuned to, particularly in this COVID time? So I'll toss it to Deanna to begin with from the PICU side of things, get the discussion started. Unmute.
I know, I was sitting there. No, thank you. So that I wanted to say too, we'll talk about it later, but there's so much stuff that we could have covered more in the preliminary topics. So if people are interested in having other sessions like this, please let us know, because we
could spend 6 hours on steroids.
Right, exactly. Yeah. We didn't talk about
steroids. We didn't even touch that, yeah.
We didn't talk about all kinds of stuff that people are going to be really interested in. So we can do more of these. This is kind of supposed to be a quick summary. So some of the things for pediatrics, typically what I'll use is norepinephrine, epi, occasionally dopamine, but not that often. We don't use probably as much vasopressin or phenylephrine as the adult side does, although I think that use is maybe starting to increase a little bit. Then I wanted to give a shout out to the POPCoRNetwork for giving a really great talk about ACLS and PALS differences. And then I also wanted to say that there is, even if it's not AHA certified, you can get a PALS an ACLS certification through a lot of great online modules too. And then for our CPR, for COVID patients, even in pediatrics, it is different than what we would typically do. One, as we've talked about before, everybody has to put on full PPE before going in, even if the patient is deteriorating, which is really difficult to do if it's a child. And I'm sure it's an adult too. 2, we have set roles. So when we do that huddle that I talked about at the beginning of every shift, we have a code protocol as well. So we also include who's going to be additionally in the room as a part of the code team. So typically we have 5 to maybe 6 people in the room for codes. And but I'm interested to hear how you guys are doing, or have you changed your practices based on COVID for that. There was some AHA updates to PALS algorithm that was out there that we can send out again. And I'm sure there were some to the ACLS ones that I didn't look at quite as much as I probably should have. So I guess
Mihir, do you have anything to add to that as a pediatrician?
I think, although we're not seeing large numbers of COVID patients in the pediatric realm, it's provided the opportunity to get creative with how you approach codes. For instance, Ken Tekma, aka at PCCM Doc, has sort of been involved in putting iPads in place, one in the room and one outside, to limit the number of personnel inside of the room. Obviously, I think everything else that Deanna mentioned, important points.
Yeah, it makes you think, does the code leader even need to be in the room if everybody can hear them? So Nick, Arun, let me turn it over to you guys. How would you respond?
I'll let Nick go. You want to talk about code response?
Sure. So I think, this is another time to say, that this thing we've said several times, which is that there are no emergencies in a pandemic. If you run into a room without PPE and you get sick, there are literally dozens or hundreds of people who won't benefit from you caring for them. So even though it's an emergency, there are no emergencies in a pandemic. You have to wait. And usually my role is I sort of take the job of officer at the door while we're all gowning up. And I'm like, look, nobody's going in until we're all ready, or at least until the people are ready. We don't have to wait for everybody, but you can't go in, with your gown half on, your mask not quite right. That's number one. Number two, Deanna, you made an excellent point about putting the ventilator brain outside the room. You can also put the pump brains outside the room. And if you do so, that gives you the opportunity to push your first ACLS med before you're even in the room. So what we've started doing, and we literally thought of this like night before last, was mark one of the extension lines that's going from the hallway to the patient as your code line. So put like a red sticker on it. Make sure you're not running stuff that you wouldn't want to bolus in that line, and mark off the dead space in the line. And so what this means is, let's say you go to a room and somebody's braiding down in the room, everybody's like putting stuff on. You can grab your epinephrine, you can push it into the line, and you can do like 3 flushes or whatever you need to get that into the patient. Typically, each extension set is about 17 mLs. So if you have 2, you need 3 flushes to get your med to the patient. So it's good to remember that math. Otherwise, you'll push your epi at the door, and then like 5 minutes later, it will hit. The next thing is, like, again, minimum number of people. We're used to having codes with like as many people as can fit in the room, but this is no time for the clown car stuff. Like, you need, if the person has a definitive airway, you need 1 person who's sort of dealing with the ventilator, 1 person who's doing compressions, maybe 1 person who's going to rotate in with them, 1 person is leading, and then 1 person doing meds. And you can kind of mix tasks. So for the first time in a while, I get to play with the defibrillator. Like, I get to actually push buttons. The nurses let me do that, or I get to push meds. So that's an important thing.
Just real quick, do you guys have the automated or mechanical compressor? Do you guys use that? Is it the Lucas? We don't use it in PICU. But.
So when I was a medic on a fire department, they used to call that the Giza squeezer because it was in Rhode Island. I wish we had that. I used to think that those things were kind of worthless because they've never demonstrated an advantage in outcomes. But I would love to have them now because you could do CPR continuously with fewer people.
Sorry, I didn't mean to interrupt your flow there. But.
No, not at all. Let me pause there, actually, because I think I covered a lot there. Maybe somebody else wants to jump in.
I guess I would say, do you, obviously you've got to flip somebody over if they're prone and going into an arrest. And, or at least, maybe not obviously. I've never done CPR on somebody on their stomach.
Me neither. And I'm super uncomfortable with that. But surprisingly, the AHA guidance says that for somebody where you can't easily flip them, like somebody who's intubated, where it might be dangerous to flip them, you can do CPR in the same place with them in a prone position.
Crazy.
Which is crazy. I mean, I guess this happens a lot in the OR, which is where they have experience with this. Because like if you're, in a spine case and somebody codes, you're not going to flip them over with their spine open. So, right. This is based on some limited experience. I'm super uncomfortable with that, but I suppose if it was a large person and we didn't have the manpower to flip them, we just have to do that.
I think just to add to Nick's point, in sort of talking about eCPR briefly, we have essentially said we're not going to offer eCPR to any person under investigation. That's consistent with the ELSO registry guidelines that they've put out.
Yeah, and just so that everybody's clear, that's offering basically crashing onto ECMO in the setting of a CPR event. I can imagine that would be horribly difficult to do in this context. Arun,
great risk.
Yeah, huge risk.
I wanted to say one thing real quick, and a couple of people have said this in the comments. We do simulations on all of these scenarios frequently in the PICU since COVID started, including making sure everybody's donning and doffing properly. So if you're not doing that in the pediatric ICU, I would highly recommend doing that. It's identified so many systems, things that we could improve.
Arun, do you want to comment briefly on pressors?
Yeah,
Pressor
sure.
choice in adults? Yep.
So it's real easy. It's norepinephrine.
Yeah.
So vasopressors, there have been so many trials. None of them have been very great, but what we know is that norepinephrine is the #1 vasopressor of choice for almost all shock states. There are certain scenarios, pure cardiogenic shock, pulmonary hypertension patients, which is the pulmonary arterial hypertension patients with a vasculopathy of their pulmonary arterial bed. Some of them may require certain other types of pressors, but norepinephrine is your go-to. And the things to watch out, digital ischemia, tachyarrhythmias, that sort of thing. And then followed with that is vasopressin, and we have it at a fixed dose. It's not a titratable medication, but that's your second line to kind of reduce the dose of norepinephrine. And there have been some studies that maybe show some renal protective stuff. And then after that, usually it's epinephrine, but phenylephrine has also been used sometimes. And I'm not the biggest fan of phenylephrine. When you're at this point, you might as well just go big guns epi. Things to consider in adults: they're more likely to get atrial fibrillation when they're critically ill, and that's common. It's not a big thing to worry about, but occasionally it can cause hemodynamic problems, and that might be the kind of person that you start a pure alpha agent such as phenylephrine in.
Great. It is the top of the hour. We had more to talk about, but I think I'll stop here and just mention to you that the other topic that we had thought we might cover would be the use of checklists. And so for those of you that are out there thinking about how am I going to take care of an adult, I can't emphasize enough the move towards checklists and the use of them and involving everybody in those checklists, whether it's the bedside nurse or the respiratory therapist or the pharmacist, but basically make sure that the care of critically ill patients in your ICU is covering a bunch of systematic things that we know actually help people out. And so so many different institutions have their own critically ill checklists. Perhaps that's something that we could spend some time talking about in another call. So it is 10 o'clock. What I'd like to do, if the panelists are still available to stick around, we could see if we could field a couple of questions that may have come up from the chat room for clarification for the next 5 to 10 minutes, and see if we can address any of those issues. So David, do you have anything you want to toss at us to address?
Can I just say one real quick thing too?
Sure.
If people are interested in having more webinars, please let us know. And again, we're always open to feedback. I just wanted to pop that in there before maybe some of the people had to leave.
Sure. Thanks, Deanna.
And can I also toss in that I made a point very early, which is make sure that you include nursing, respiratory therapy, physical
100%.
therapy, occupational therapy, speech therapy, pharmacy. All of this is integral to making an ICU work, which is probably preaching to the choir in the pediatric ICU, but especially developing adult protocols. It doesn't have to be starting from scratch. You probably have a medical ICU nearby that you can adopt a lot of their protocols from.
All right, let's field some questions if there are questions out there.
So we've had a number of things come up throughout the session. One of the early ones that came up was the context of when to consider CT scans and CT angiograms. We talked a little bit about the role of pulmonary embolism specifically in COVID, but that this is sometimes a nuanced approach, especially because not all of us have access to scanners that can regularly be cleaned.
Can I just say one thing before people answer that I think is really important too? That's a great question, but I want to put in a plug to get the palliative care team involved early for a lot of these patients. We can talk about that again, and now I'll throw it back to your CT question.
Sure, I think that is a great question. One of the points that we've been doing for our patients has been to actually minimize all radiology. So we only get x-rays if we absolutely need one. And it turns out there's actually good literature to support not getting a daily x-ray on an intubated patient. But that's a really hard thing to change culture on. But we're trying to minimize radiology, and by extent, we're really minimizing trips out to go to the CT scanner. I think that if you've got a suspicion for concern for a PE or thromboembolic event, it's probably just as well to, your D-dimer on these patients is always going to be positive, to consider empirically anticoagulating them rather than risking the trip downstairs. I know that some of the institutions in China were getting CT scans on everyone, but that's in a place where all your patients have COVID and you don't have to clean it after every single one. We're certainly not at that point, but I don't know if the rest of you have any opinions on that. We're not trying to get CT scans at all as a general rule.
I think it's based on your hospital too. If the hospital has a high volume throughput that they can clean really quickly, you might be able to have more access to scans. But not just x-rays, but nursing care, anything that requires people to go in and out of the room. You have to think really hard about if a medication can be timed with the patient's lab schedule, that'll decrease the amount of times nursing has to go into the room. Same for x-ray techs, RTs, etc.
Yeah, I would say now is a great time for point of care ultrasound. So, when I'm, admitting these patients, I'm trying to do a good ultrasound exam on them just to establish a baseline, because there's a pretty high likelihood that I'm going to have to go back and examine them at some point later. Whether it's looking for lung sliding to rule out pneumothorax in somebody who has suddenly developed a change in their compliance, whether it's looking at their heart to evaluate if this person may have had a drop in their EF or may have developed RV failure, or whether it's just, looking, something else that comes up. It's nice to have a sense of, when you're putting your lines in and stuff, when you admit them, you can take 5 more minutes and do a little bit of an exam, and then you'll have a sort of a mental check for later.
I had a slightly unrelated question for you guys. Since the limitations of visitations for family members with infectious disease prevention in mind, how are you engaging with families, and what is your approach to calling and updating families? Because it's such, especially for the patients who are dying.
Go ahead, Nick.
I'm not in the adult side all the time, but I would say our hospital just instituted a bunch of virtual ways to talk to the family and to have the family talk to the patients as well. And they instituted a program, I can't remember exactly what it's called. It might be called NOVA or NODA, like No One Dies Alone. So there's volunteers that will sit with like an iPad with somebody who is going through that. But it is a good question. I would like to hear from people who are aware of this more.
I mean, for us, we were calling people every day. And actually, I want to make a point about that. Because we're the ICU that I work in is shift-based, we have in our daily notes the phone number and the name of the person that we talk to and when they talk to them. And we carry that forward every day because there's a different intensivist that may be talking to a family member every day. And so we're actually intentionally trying to really stay on top of that because families aren't allowed to be there. But we were basically trying to call folks at least once a day. I don't know if you guys have a similar.
Yeah, we've been doing the exact same thing, keeping that information readily accessible in the chart, just like that, copy forward. I would say that personally, this is one of the most distressing aspects of COVID for me, which is that it's so hard to communicate with families, which is usually such an important part of what we do. They say that in terms of what in communication, about 5% is the words you say, 15% is how you say them, and 80% is the context and body language. And when you're having a conversation over the phone, you get only 20%. I guess an email, you only get 5%. But it's really challenging to, call up somebody, give them bad news, and that's your style of interaction. And one of the best things that you can do to make it easier is exactly what you said, which is make sure you're having a daily call with them.
And including, I think, other teams too, like palliative has been really valuable.
Yeah, absolutely.
Even if they're not going down the hospice route, having some of the palliative team might have some extra time to listen to them. One of our PICU intensivists also does palliative care. A couple of them do. And so they've reached out to volunteer to help with those services on the adult side as well, which I thought was really, really wonderful.
All right. Well, it's 10 minutes after, and I think I'd better be respectful of everyone's time and wind this thing down. But I'd like to thank all of the panelists. You know, most of us are on Twitter, but certainly thank the Popcorn Network for putting this thing together. And let us know if you liked it. Let us know if you want more. We can certainly go into more discussion about specific organ systems to a greater extent, or therapies that are on the horizon, or other differences in other organ systems like the kidneys and renal failure, or how do you feed an adult versus feeding a kid. But yeah, thank you all very much, and a big thank you to my panelists. Yep.
Thank you, guys.
Thank you.
Thank you so much.
Group. Yep.
Everybody take care.
Thank
Take
you.
care.